Welcome everyone to episode 23 of the Exoskeletons and Wearable Robotics podcast with me, Bobby Marinov, Exoskeleton Report, and Dr. Tom Sugar from the Wearable Robotics Association. We have with us Rob Nathan, the Director of Operations at Bionic Power, and a very special guest, Gualtiero Dani. How did I butcher your name completely?
Perfectly.
Perfect. CEO of Bionic Power. So thank you guys for joining us. Today we'll be discussing medical exoskeletons with a focus on pediatric. And Bionic Power, quick overview, is one of the first commercial exoskeleton companies. Even though you might not hear as much about them as Exobionics or Rewalk, they're one of the founders of this industry, and they have a very long and colorful history. So hopefully we will get to touch on that too. Before we get started, special thanks to our Patreons, our VIP tier supporters, Volker Bartenbach, Rita Vasquez Torres, Minmar, and our corporate level sponsors, Humotech, Oxivo, HeroWare, and Digity. Thank you guys for your support. And if you like this content, please support us on Patreon. It is both a financial support and a moral support too. So thank you everyone for joining us. How about a quick introduction for those that are not familiar with Bionic Power and you?
Yeah. So first of all, thank you very much, Bobby and Thomas, to host us in this podcast. So I'm the CEO of Bionic Power since 2021. The company was actually founded in 2007. So we have a long history with wearable technology. The original idea about the company was a lightweight wearable, not to help supporting, but to use the passive movement of the knee to generate electrical power. The idea was to give the army a device that they could use to reload the batteries that they use for their toys, almost at no cost. And actually, when they were going downhill, they were actually saving energy, especially when they were carrying big loads. Now, the product got to TLR 7.8, was really tried on the field with great success and maintaining all the requirements that were asked from the US DoD. The only real problem for adoption was that in the same time that battery technology made a lot of step forward, and finally the Army stopped using lithium battery at some point, much more recently than anybody else in the world, but there were some safety issue, I think. And so a use case that was the day before was saving a few kilos from the backpack of a soldier became a use case for saving a few hundred grams. You know wearable technology. Nobody that knows wearable technology will wear a wearable device for saving a few hundred grams in the backpack. So the project went nowhere. We tried to pivot the company initially to an hybrid augmentation generation device, but it was very difficult to find, to optimize the device for every kind of use case. And so at some point, we entered in contact with the NIH, which was using a very similar apparatus for helping kids with cerebral palsy to walk taller, stand taller, and walk straighter. And our device was perfect for that. And instead of being a bulky lab device as the one they were developing, it was already developed with a lot of contribution from the military. So it's a fantastic case in which military expenses has contributed to the development of the device for a particular category of patient, like the pediatric, which are normally not targeted by research investment. So it's really, from the human perspective, is really something fantastic that happened. And I'm very proud of leading this company in that direction.
I'm Rob Nathan. Thank you guys both for having us on the podcast. Been really looking forward to this. I'm the director of operations now for Bionic Power, but actually I'm an industrial designer. Been doing that for the last 25 years and had been an industrial designer for Bionic Power before slowly moving up to the director of operations. And Gualtiero summed up the product pretty well. The history of it. So the device now, since we're 100% medical, we originally targeted pediatrics, and what we targeted was crouch gait for the most part. So crouch gait is common with cerebral palsy, spina bifida, can also be post-polio, muscular dystrophy, and some other conditions. Basically, the idea is that these children, and adults as well, but we were targeting children originally, they walk with their knees constantly bent a little bit. So they're not able to, whether it's because of strength or contractures, get that full extension. And it's only when you have that full extension during the stance period of walking where basically the skeleton can help hold you up. So if you imagine walking in a squat all the time, it is exhausting. So typically what happens with these children is by the time they reach adulthood or potentially even right at puberty, they'll put on more mass and their muscles won't be able to keep up to it. So they're not able to power their own legs enough to get full extension. So what our device does is it gives that assist. The wearer is in full control. It's all based on their own motor control. We don't institute a particular gait. We follow their gait. So not only does it then help them get that extension, if they have any problems with flexion, we can also assist there. Another aspect of it is we can actually run everything in reverse so that they're actually working against that assistance. So it is resisting them, and it then becomes an exercise tool as well. After doing pediatrics and focusing on that for a while, we found that there are numerous adult cases as well, not just crouch gait, but there are other conditions such as either post-polio or post-stroke hemiparesis. In a lot of cases, what this results in is the person can't lift their shank. They can't flex their knee and lift their foot up. So they end up circumducting or changing their gait in other ways to make up for that. By using the Agilik, and in that case, especially post-stroke, it tends to be unilateral, just on one side. Very easily, with low torque, we can enable them to have a completely normal gait again by lifting their shank for them. And again, it's all based on their own motor control, so they initiate steps. They're doing the movement. We aren't instigating it. We're simply assisting with it.
When we started this project, so coming from our harvesting experience, our augmentation experience, we were under the impression and the conviction that for helping an adult, you need something like 30, 40 Newton meter of torque at the knee to make any difference. And we then realized that this is not actually the case for the patient population we are talking about. So those numbers are true, either if you want to do augmentation for industrial use, or if you want to make a significant difference for someone that is completely paralyzed. But in many, many cases, we are talking about patients that have a stability issue or that have some weakness, but they can walk on their own. So our devices can just provide 12 Newton meters. But 12 Newton meters, when added to what your muscle can do already and your motor control can do already, can be a fantastic support. And it turned out that more often than not, we are using torque level that are higher on the pediatric crouch gait than on patients after stroke, that what they need is a little bit of help for flexing in swing or for stabilizing their knee in full extension during early stance. Because at that point, 12 Newton meter are a lot, more than enough. We have a very small battery that lasts super long, more than a day. We are actually thinking about reducing the dimension going forward at some point. And the whole weight of the battery is a kilo, including the battery, the fanny pack, and the weight of our joint is less than half a kilo per leg. That then needs the custom knee ankle foot orthosis component, which can be from 1 to 2 kilos, depending on the material that you're using. So maybe now is the time to show what the device is about, because there is another very important difference from the typical wearable approach. This device is custom, so you cannot adjust the dimension to a particular patient. The device itself is a sort of powered knee hinge that needs to be installed on a custom KFO. The one that is shown here is a super fancy carbon fiber. You can use also cheaper materials like polypropylene, like in this case, and is done on the specific cast of the patient, of the leg of the patient. This is also another reason why a low torque is very effective, because in this way you have an interface between the human body and the orthosis, which is much better than in any other adjustable exoskeleton.
So is it safe to visualize the slower torque as like having a physical therapist hands on your leg and they're pushing you, accelerating, decelerating the leg to clean your gait?
Bobby, I think this is one of the best definition that I ever heard about our device, is exactly what the device can do for you.
Wonderful. And then I've been following the progress of your company for quite a few years, and as is the case with all of our guests, everyone seems to be very humble. So Bionic Power had one of the first devices that really figured out transparency and making it feel like the exoskeleton is not there. I remember seeing multiple videos on YouTube back in the days of soldiers dancing, jumping, running, squatting in all kinds of positions with the Bionic Power at a time when exoskeletons were still bulky. So thank you for the outline, but also to emphasize how many achievements Bionic Power has had over the decades.
I can say that I'm even prouder when I can see a little girl dancing on stage with our device more than a soldier squatting, because a soldier has physical condition that allow him to squat with almost every possible existing load on his leg. But if you look at this short video, this was taken at during Anger Live. Anger is a partner we are working with, and they are running a trial in this moment with more than 25 kids that received an Agilik so far, and they are giving the device to the children to use for 3 months, and they observe them for 3 months. And in many cases, like in the case of Catalina, we really saw quality of life changing. This girl was going to school with a wheelchair, not because she's not able to walk, but because her crouch gait was making her walk super tiring, super energy costly. And with the Agilik, she can walk for the whole day. She plays tennis, she dances, she does everything in her life. And I can tell you that the maximum torque level used on that girl is probably 4 Newton meter, nothing more than that. But the important part is helping her maintaining a posture that is energetically more efficient.
Yeah, another anecdotal story, sorry, Tom, from the same girl is that October 2 years ago, she went out and trick-or-treated and made it to 2 houses. And, that was enough to tire her out. Just last October, with the Agilik, she went out for 2 hours. She was the last in her family to be like, okay, it's done. We've had enough trick-or-treating.
Yeah, I was going to make a comment that it was absolutely fantastic. And I was also making a comment for people just listening to the podcast that the young woman was dancing and moving around and she wasn't using crutches. So I was going to make a comment that do you have to have the crutches? But it looks like you don't. In the pictures you were showing, you've got, 2 or 3 people using crutches and you've got 2 or 3 people, not using crutches. And one person looks like they're using a rollator.
Typically, and here we are entering also in the regulatory of all these medical devices. Typical what we are suggesting is that they keep using whatever tool that we're using in advance, and then they can take a conscious decision. So again, some kids will continue to use crouches, some kids will not. In general, if they're using crouches, you will need to extend their crouches. Like this kid, Paxton, that the video is showing now, you see his crouch gait. He was using crouches with the crouch gait, and he received the Agilik. The first thing that they had to do was changing the length of the crouches. It's a complete, you see, he's using crouches because they give him stability, but the posture is completely changed. It's not the same posture. And he can really take the school bus and go to school without the need of the wheelchair. He also can do some short family trip, leaving the wheelchair at home. Sometimes he needs it because he's a wheelchair basketball player, so he also likes it. But he can do a lot of things without it. I love this video that we are showing because it's the very first case on which the Agilik was used at the NIH. So at that time, we were even using harnessing system for safety, as many have done in the field. Again, it was a spina bifida girl, and the device at that time was a prototype. We had much less software control possibility, so you can notice a little bit of hyperextension at every step. But nonetheless, she was much faster. Her steps were longer, and the device was making a big difference for her.
So if I'm hearing you correctly, adjusting the slight hyperextension from the original prototype was all handled using software.
Yeah.
Wonderful.
So the way we control hyperextension is, and here I'm sorry, I have to become a little bit more technical, but I'll try to simplify. Our device doesn't control position. Our device controls torque. So we recognize by means of sensor feedback, we recognize in which phase of the gait you are, and the orthotist or the physiotherapist can set the device to apply a certain extension or flexion or in each phase of the gait with some, and they can also adjust the ramp rate. When the device is getting to what is set for the full extension of that very patient, in the last 5 to 10 degrees, it starts controlling position to do not go over hyperextension. So it can reduce torque and even apply a flexion torque in a very fast way to avoid hyperextension. This is not super important on kids with crouch gait because typically they cannot even reach, they have contractures that do not allow them to reach full extension. It's very important for stability in patients in adults with unilateral use.
Wow, yes, right. So you also have the capability to do unilateral use then, to have only one.
The device is actually a unilateral device, so the two legs are controlled in a fully independent way.
Listen, this woman was a post-polio patient, and she only has hemiparesis on the right side, so she's using it unilaterally.
So what I was hearing, Bobby, is that they're saying, which I've tried this before myself, which is you're going to control the right side one way, you're going to control the left side a different way. Because even on able-bodied subjects, when we were doing some hip exoskeleton work, the one side is slightly different than the other side. You think that you're walking in symmetry, even if you're, quote, perfect, you think you're walking in symmetry. But it depends, like let's just say your right leg is a little bit stronger. You actually reach further. You actually have a little slightly different, gait on your right side than your left side. So that's quite interesting.
Yeah. So the only thing, when you use that bilaterally, there are a couple of things that are controlled in a way to, let's say, if the right leg goes on error mode, we put in error mode also the left. But those are just safety check on top of the normal control. But the state machine is run independently on the left and on the right. So, and by the way, when you are standing, you have both leg with the foot contact. When you are walking, it's typically one leg only at the time that has full contact. So
yeah, really impressive videos. So just for our podcast listeners, there's videos of people walking, over ground, walking indoors, walking outdoors, people dancing. Just really impressive. It looked like even one of the little kids was almost jogging a little bit. So I was going to say, is there any limitation? Obviously nothing's going to be perfect. So is there any limitations? Do you allow people to jump, jog, or just right now?
Let's say we're not suggesting or teaching to do that.
I understand.
But when a kid start using a device like the Agilik and start finding his balance, and then the sky is the limit. You cannot tell them. You can tell them not to run with the Agilik, but they will do that anyway. So what we are doing is internally we are testing the device for those things, but we are not suggesting on using it. We have recently introduced descending stairs mode and descending ramp mode. So you can use the device upstairs without any change in setting. To go downstairs, we basically take off what we call the late stance phase, in which we typically apply zero torque or a slight flexion. And we keep applying the same torque that we are applying in early and mid stance, in late stance during stairs, because you need to continue to support the flexion. And it's also a fantastic way to recharge your battery. If you go downstairs, if you walk downstairs, you are recharging your battery more than using it, because every time your knee angular velocity is in a direction that is opposite to the torque application, you are charging the battery with a super high efficiency, because don't forget, our device was designed for that and we didn't change the motor gearbox.
That's super exciting. Once we were building some phase oscillators for hip exoskeleton, and we did extremely well going upstairs, walking, jogging, jumping, but then going downstairs, you kind of had to reverse kind of what you're doing. But it's extremely exciting to see that you have a commercial device that is allowing people to descend downstairs or go down ramps. So quite impressive.
Yeah, and by the way, we have in mind, and this is a question for you, Thomas, we have in mind to make at some point, as soon as we have some bandwidth with the engineering team, we would like to revamp an idea that we realized for the NIH once, which is a sort of research actuator in which we open up the possibility to implement whichever control system that the researcher want to implement and sell those to research group like yours to do actuation research. A system that a mechatronic component which is commercial grade and market rated.
Yeah, no, I think, yes, I think that's important. We've, in some of our podcasts, Bobby has talked to some other groups about looking at research, and actually just a pitch to Bobby's exoskeleton report. He now has a new category called research. And I think that the community, you know, if we come together and work on commercial grade systems, then we can move faster, right? You know, if you have commercial grade motors and batteries and electronics, you know, why go through that, you know, all that FDA work, right? If someone's got some pieces that work together.
Yeah.
And the students win because you can have university level labs with commercial grade exoskeleton technology, wearable robotics technology, which can also be applied to humanoid robotics, and with pre-made kits.
With the limitation of this device that actually from the regulatory perspective is a microprocessor control system. So our device is not a medical device on its own. It's a class 1 device that could be integrated by a professional certified orthotist into a KFO. So that's
really exciting
the status of this.
And then you mentioned that this is a commercial device. So can you tell us more about how does one acquire or get reimbursement?
Yeah. So this picture that Rob is showing is our test drive unit. So typically orthotists that are using the Agilik, they have a test drive unit which can be adjusted to almost any different body size from adult to pediatric. And a patient can try this device using their own KFO if they wear one inside our Agilik, inside our test drive, or their own AFO or nothing, and see if this device can be helpful to them. This is the first part. After that, if the device can give them the right result, their clinician, their doctors will have to prescribe them make a prescription for them to get the Agilik. They will go to their own certified orthotist, and the certified orthotist will cast their leg, will make the KFO or order the KFO from a central fabricator, and will install the Agilik on the KFO. And the Agilik is, as I told you before, is a microprocessor stance and swing control orthosis, knee orthosis. So is reimbursed under a particular CMS code, which is I don't remember, HCPD something, L206. We have a PDAC letter for that, and is reimbursed around $37,000, $38,000 per leg all over the United States. Not all the states, to be frank with you, have Medicaid accepting this code. So for the pediatric use, there are states that reimburse that, and there are states that will consider it still a research product, although they are rapidly adapting. And some of the private insurance consider this code as a medical necessity, others still do not. We are working with two main distribution chains in the United States. We are in the pre-marketing, so they're not actively pushing yet. They will launch the product in the fall. And the two main companies that are working with us are Enger, through the Enger clinics, and One, which is a French company very active in the United States, and they have a fantastic technology for making carbon fiber KFO without the ankle joint, using a sort of carbon spring for the ankle. And both of these companies actively working with us, and they both participated in our Series A funding round last summer. So they are invested in the company, and they are also our principal sales channel.
Wow, amazing. So you don't have to pay for this out of pocket necessarily. There are ways to get reimbursement.
You know, that's a very strong statement, because not everybody has insurance coverage. If you have the right insurance coverage, and if your provider goes through the right process and provide the right outcome report for you and put together the right story, chances are you will have the full reimbursement. And we know for sure about around 10 patients at this point that got the device paid by the insurance. We are still at the very early days of this process, so more to come on that.
But a success story in the sense of originally some Army technology morphing into a medical device, then actually commercializing it, getting it with hanger prosthetics. And I didn't catch the other French group, but another group as well. And then the ability to create a distribution channel. So I think that's where sometimes, I'm just going to make a broad comment, and Bobby, you could agree or disagree, but that's where sometimes some of the wearable robotics companies haven't moved down the commercialization methods, where it's like, I've got the technology, I've got the product, but now I've got to have distribution channels, and I've got to have, insurance methods to help to pay. So for people that were on the podcast, they were showing some slides that talked about the codes that you could use to get this paid, and the product classifications, and that people have been able to get funding through some of the insurance companies in different states like Alabama, Arkansas, Arizona. For us, Arizona, and then California and other states. So
yeah, this is the list of the reimbursement that we have presented. There are reimbursement in every state of the United States. Not in every state Medicaid has accepted the reimbursement code. Medicare has accepted that everywhere. Here is for adult. Medicaid is covering most of the kids that this device is intended for. So again, I don't want to talk about reimbursement too much money. I'm not an expert. We have partners that are working on that, but there is a mechanism in place, and if one can assess those mechanisms, the mechanisms work.
And maybe you could comment on this. And too, in a previous podcast, we talked about how important it is to work with children, and there's not many people that have done it because it's, harder for the IRB research and things, but how important it is to work with children because you can make a difference in their lives for the next 50 to 60 years. And so I think that's maybe for our viewers and listeners, that's something we could discuss maybe for a couple minutes where, if you get a child out of a wheelchair and up and walking and they're at school and they're more satisfied, what a difference you can make over the next, 30, 40 years.
Yeah. So let's try to highlight a couple of facts and then a couple of hypotheses or speculations. So one fact is, and we have a lot of papers already published and some in publication that says that we can definitely improve the biomechanics of gait for kids by using the Agilik. So we improve, and there are measurement that you can do. Like we can change the maximum extension in mid stance. We can change the speed of the gait. We can change the length of the step, all in a positive way, leading to a much better biomechanics. We can increase, and this has been measured as well, we can increase the endurance of patient walking. What is difficult to prove is that we can keep them out of the wheelchair. That's a much more onerous proof to give. We can speculate that someone that spend less energy walking, someone that can walk longer, someone that use the device will last longer in terms of walking and will use the wheelchair less and will not need to be seated in a wheelchair forever. It's a speculation based on the fact that, every physiotherapist will agree on. The more they walk, the better it is for them. So, but again, this becomes something that is difficult to prove. You will need a multi-million-dollar and
Many years.
studies that I don't know if we will be able to do, if anybody will do, but probably they will be available when this technology will be already obsolete. So it's not easy to do that. It's easy to make hypotheses, it's easy to speculate. And also, I think each family will know their kids and will know or will make a good assumption on how much their kid can be compliant to this device. We have noticed with some of the trials that have been running or that are still running that there is a big difference in the time of adoption of the technology, how much they use the technology every day. And these differences are related to severity of the initial pathology, to the family support, and to the age of the patient. Typically, teenager, even with very important benefit, more adverse to wearing the device every day, to wearing the device at school and to show the device to their classmates. Children in, let's say, in the age range 6 to 12, they don't care. They use the device all day long. So,
And typically what we're hearing is that their classmates love it. The classmates are really interested. They're very curious and super supportive. But as Gualtiero said, it's the teenagers who it's pretty hard to get them in it.
Yeah.
and it's the category that can benefit the most, in our opinion.
Right. Right. Oh, that's interesting. Yeah. Once I saw a journal paper, they were saying this was for stroke rehabilitation and they were wearing a hip exoskeleton. And they were saying, we're not going to tell you whether the gait was better or not better. All we're going to tell you is that when they don't wear the hip exoskeleton, they were doing, let's say, 1,500 steps a day. And when they were using the hip exoskeleton, they were doing more like 3,000 to 4,000 steps a day. And that was kind of their hypothesis and conclusion of the journal paper. So, sometimes, you're never going to, it'll be impossible to sit there and collect, perfect, gait data or EMG data or anything like that. But if you can at least just say, especially for those children from 6 to 12, here's where their steps per day were X, and then steps per day using the device is Y, something like that. But anyway, quite exciting.
I mean, if we go back to Catalina that we showed picture of before, she came back after 8 months because she grew and she needed a revision of the KFO. And he told us that her step count was around 1.5 million steps in 8 months. It's a huge number for a spina bifida kid with her condition.
That's I would get the people out there and walking, but it's the mechanical problem. So we were building a robotic ankle at one point, and the Army said they wanted 5,000 steps a day, and it had to last 5 years. And so when you start to count up the cycles, it's shocking. So just for our viewers to understand, it's much, much harder to build a device with 1.5, million cycles, because the motor's got to move back and forth for every cycle. Then we were talking about it's a lot harder to build a prosthetic ankle than it was a car, right? Because if you look at how many cycles the wheel rotates on a car for 100,000 miles, and then things break down after 100,000 miles.
Yeah, so
It's an interesting problem.
our device is tested for 2 million cycles between one maintenance and the next one. And we use, unfortunately, we didn't prepare a movie on that, but we use a machine that reminds a lot of that IKEA system that they were using for testing chairs. At some point, they had a sort of elastic chair, and they were using they were showing in every shop this machine that was pushing the chair up and down to show how long it was resisting. We have an artificial leg that goes back and forward, and we are testing the device on that. We have devices always running for millions of cycles. And again, it was designed with the Army requirement. The whole gearbox is not changed. So the gearbox is super resistant.
Fantastic. There was visions in my head. We had a artificial leg pounding an ankle on the ground, and you would just hear this thump, 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 thump. Anyway, it's just interesting times. But thank you.
And then you mentioned also clinical studies. Do you want to touch on that topic?
Excuse me, can you repeat the question?
You mentioned clinical studies with the Agilik. I was wondering if you or Rob would like to touch on that topic.
Oh, yes. The best way to find every information on that is going on clinicaltrial.gov. Most of the trials are registered on that website. And we have trials ongoing in Europe and in US with the NIH. Those are trials more oriented to measure the rehabilitation effect of the Agilik. They give the Agilik to patients for 2 or 3 months with a couple of different settings, one for exercise, one for support. And they have to do a 1-hour exercise every day. The rest of the day, they can use the device for assistance, pure assistance. And the endpoint in this case is measuring how much they can get the muscle to become more powerful. NIH is leader in that kind of studies. Some paper was already published more on the short-term effect. And I think they will be presenting the results of this new trial, most likely at AACPDM, which is a National American Congress on CP and other developmental disease in September, October. The study in Italy is ongoing. I don't know exactly when will be published. And there is another study which is not on clinicaltrial.gov which is run by Enger, which is called the Avenger trial. And it's really oriented to show the improvement in the activity of daily living. And for now, they have enrolled, I think, 20 out of 25 kids, and they already plan to present the results at AOPA, American Orthotic and Prosthetic Association. And if you go on the website, you already have that presentation as part of the official program. Other studies ongoing. We have a study on which is really, again, a biomechanical short-term trial, which is started at HSS, Hospital of Special Surgery in New York. And we are doing some research also in Canada, more oriented to tracking daily living. Is a database that has been just approved by the ethical committee from University of Calgary, in which every user around the world want to register will provide some information on their daily use of the device in order to track how the device would be used in the clinical practice.
Fascinating. Oh, I see we have another guest also now to the podcast. Who is that behind you?
Oh, myself. Yeah.
The dog poking up.
Well, hi.
The various trials and also all of the published papers that are either specifically about the Agilik or a lot of ones that are relevant to it are all on our website. If you go to the try it out section of the top left of the website, it'll pull up a Google map that shows all the different distributors around the world and the different trials that are actively seeking participants right now.
Fascinating. And that is at Bionic Power,
Power.com.
bionic-power.com. Excellent. And then we have a listener question. Since we have you as guests and as premier experts in exoskeleton technology, can you help everyone make sense of all the AI hype that is currently happening in the world, where suddenly every product is AI enabled? Half the exoskeletons are suddenly AI exoskeletons. I think it's becoming a little bit difficult for everyone to understand what is hype, what is science fiction, what is the reality. So where do you stand there, and how do you see the future as well?
So I'll try to answer to this question. We are probably too humble to face the competition on that. So for me, it's very tough, and we are not saying that our device is AI based or AI enabled. The reality is we are using, and we have started using, some machine learning algorithm to train the device. And especially, so I don't know if I explained that, but the way our device works is we have a foot sensor resistor, an FSR foot sensor that measure if there is foot contact or not. And that give the device the information if the patient is on that leg in swing or in stance. And then we use the feedback from the knee angle and angular velocity to determine in which phase of stance, early, late, or mid we are, or in which phase of swing we are. We are trying to move away from the foot sensor, which is a wear and tear part, and to use instead an IMU at the foot and an IMU at the ankle. And we are using a machine learning approach in order to train these IMU to recognize different phase of the gait with different gait types. So yes, we are doing some progress in AI on that direction. The other big thing is the software team is more and more using AI tools to streamline their coding processes.
Yeah, even an exoskeleton report, I've gotten to do a little bit of that. Got a new web scraper going using AI enabled coding. Fun times. Well, thank you for clearing that up. Tom, do you have any other questions?
I don't. And so, but it's been a really great, informative presentation, and just really remarkable how well some of those children were walking. So we usually always give our guests a chance. Is there anything we missed?
No, I think it was a very, very complete session. So again, we are in this pre-launch phase in which the product is already commercial. It's not truly pushed everywhere, but we are getting there. We are getting there pretty fast. And so whoever has question for us can go on our website. We have a contact form, and we tend to answer to everybody and to help them navigating the process. Of course, we cannot sell directly or Agilik directly to anybody, but they will have to go through their doctors and clinicians, but we can be available to answer questions.
Yeah, and we're very active doing demonstrations, whether we send someone to a clinic or to a hospital to do a demonstration potentially for one patient, or we can do up to probably 10 a day with our test drive unit where they can actually try it on, potentially use, as Gualtiero said, their own AFO in it or their own KFO with ours going over it. And then they can actually experience what the Agilik is really like. And those demos actually aren't just for the patients, they're also for clinicians, for orthotists, physiatrists, orthopedic surgeons, etc., to really see what the actual effect is and to feel it. Once you feel it and you've used it yourself, it gives you a very different perspective on it, especially for doctors who've done things for, decades the exact same way because they've worked. This is a very different tech. And it kind of makes people rethink some of the stuff that they thought that was an absolute fact, such as a rigid ankle AFO for someone with spina bifida. Well, if they're getting assistance at the knee, they may not need a rigid AFO. And we're actually doing a study on that again at the University of Alberta in Calgary, where one of our interns is doing his master's program and studying exactly what ankle is best. Is it with the Agilik? Is it rigid? Is it flexible? Is it a certain amount of resistance in both directions to help with plantar and dorsiflexion? So some things we just don't know yet, and we're still experimenting with, but it's definitely changed how people can look at some of these conditions and the effects of those.
Wow. Yeah, it's fascinating, amazing.
Thank you guys for the opportunity.
Thank you. Thank you all for listening. Thank you to our guests for joining us on episode 23 of the Exoskeletons from Learnable Robotics podcast. We have a weekly newsletter going strong now for over 30 editions. Check out our other episodes. Go to bionic-power.com to learn more about this amazing work that's been decades in the making. Visit the wearablerobotics.com website to learn more on the Wearable Robotics Association, which is dialing up its efforts in the US while continuing to focus on Europe as well. And of course, check out the Exoskeleton report and support this effort on Patreon. Thank you all for your time and have a great day.
Thank you. Bye.
Thank you.
Thank you, guys.